Hey, everyone. Great. All right. Welcome, everyone, to our update on canine leishmaniasis. And this is a webinar organized by the Canadian Animal Health Surveillance System, as well as the American Kennel Club Canine Health Foundation. So we're going to get started. And so our agenda for today. So my name is Dr. Doris Leung. I'm the director of the Canadian Animal Health Surveillance System. I'll be going over the housekeeping items, and then I'll be speaking a little bit about CAHSS, what we do, and our Companion Animal Surveillance Network. Unfortunately, Dr. Sydney DeWinter is sick today, so feel free, Sydney, if you're here, give us a little wave. So instead, we'll have Dr. Katie Clow provide an introduction to our webinar, and then we'll have a structured Q&A with Dr. Scott Weese, Dr. Guadalupe Miro, as well as Dr. Christopher Fernandez-Prada. And then after the structured Q&A, we'll have a Q&A from our webinar participants, such as yourselves. So in terms of some housekeeping items, please keep yourself muted. If you have any questions for our panelists, feel free to use the Q&A box that should be at the bottom of the Zoom toolbar, and these will be answered at the end of the webinar during the Q&A period. If you have any IT questions, if you're having a hard time logging in, you could email us at cass@animalhealthcanada.ca, or you could message the host in the chat box and we can get to you as soon as we can. This webinar is recorded and it will be shared shortly with our participants after the session. And I also wanted to mention we have RAISE CE approved for 1.5 hours, and the certificate for that will be sent shortly to our participants after the session. And a caveat is that we're only providing this to those that have attended the live session today. All right, I just wanted to mention a little bit about the Canadian Animal Health Surveillance System. We are a division of Animal Health Canada, and we serve the surveillance pillar within Animal Health Canada. We work very closely with our sister divisions, including the National Farm Animal Care Council, as well as Emergency Management Division. And CAHSS's vision is to have a shared national vision leading to effective, responsive, and integrated animal health surveillance in Canada. And we do this by trying to bring together and use data-driven information to demonstrate animal health, minimize the impacts of disease, and also to guide surveillance planning from a national perspective. And so CAHSS is, we have a network of networks. We have 7 species-specific networks, and that includes our aquatic, beef cattle, dairy cattle, companion animal, equine, small ruminant, poultry species networks, as well as 2 special topics networks, including our antimicrobial use and resistance network, as well as our vector-borne disease network. We also have a smallholder working group. And so as of June, of yesterday, actually, we have close to 700 members within the Canadian Animal Health Surveillance System. And so I just wanted to share a little bit of information about our Companion Animal Surveillance Network. And this is actually the newest surveillance network within CAHSS. We launched back in 2021, and we currently have 180 members within our listserv. And we usually have around 30 to 35 active members that sit in on our network calls. And so we meet every 3 to 4 months online over MS Teams or Zoom, and we're sharing a lot of relevant information on different diseases or signals of interest relevant to companion animal health. We're sharing lessons learned from different surveillance programs and projects. We're also asking the community of national experts questions. And so we actually have a diverse range of membership, and these people include, we have government staff from all levels of government, including federal, provincial, territorial government. We have diagnostic lab staff from both private and provincial diagnostic labs. We have representation from academia as well from industry, pharmaceutical industry. We also have participation from regional and provincial surveillance partners. We also have membership participation from private companion animal practitioners as well as animal health technicians. We also have vet students participating on our calls as well. And so I just wanted to share some screenshots of some highlights from our companion animal surveillance networks. And so we've created, in the last 2 years, we've been able to collaborate with the Ontario Animal Health Network to create a canine distemper infographic available both in English and French. We've had, 2 years ago, we had a Cross Canada check-in on animal health surveillance, so a Cross Canada panel. And we're also able to create close to near real-time disease alerts relevant to companion animal health in Canada. So this is our last slide. I would encourage everyone today, if you're interested in joining our network groups, you could easily do this by going on to CAHSS.ca and clicking on the navy Join Us button. And if you have any questions, feel free to email us. It's CAHSS@animalhealth.ca. And with that, I'll leave it. I'll bring it over to Katie, Dr. Katie Clout, with her introduction.
Great, thank you, Dr. Leung. I'm just going to share some slides. We see that okay?
Yeah, it looks great.
Great. All right. Good morning, good afternoon, good evening, wherever you're calling in from. My name's Katie. I'm an assistant professor at the Ontario Veterinary College. I am stepping in last minute because our main moderator, Sydney DeWinter, unfortunately woke up very ill this morning. So I will try and do her slide deck justice. And then I'll be moderating a Q&A with a really stellar panel of experts, Dr. Christopher Fernandez-Prada, Guadalupe Miro, and Scott Weese. So just as an overview for the next 15-20 minutes, I'm just going to give a brief overview of canine leishmaniasis, some of the most important information to know, and then in our structured Q&A, we've compiled a list of common questions that have come in from practitioners that to answer some of those burning questions that are out there. And then anything that's not addressed in that structured Q&A with our experts, we'll have that open Q&A option as well. So what is canine leishmaniasis? It's a vector-borne disease that's caused by Leishmania species. There are many Leishmania species globally. Some of which are zoonotic. They're protozoal parasites. And when we're thinking about canine leishmaniasis, we're predominantly thinking about Leishmania infantum, to a lesser extent, Leishmania brasiliensis. And there's some other species that have been identified in dogs, but these are the main drivers that we see in canine leishmaniasis disease. It has wide global distribution. It's considered endemic in over 70 countries. This endemicity status is mostly based on vector distribution. So we'll go into transmission shortly, but where the parasite exists and the vector sandfly and hosts, we can have local transmission, and that's where we get sort of our endemic foci of disease. You'll see on this map on the left-hand side, which was developed by Scott Weese, to give us an idea of where the disease is considered endemic. If you see the sort of darker pink red, these are our highly endemic areas. The lighter pink still endemic, but lesser so. And then as the colors change, we get into areas where it might be sporadically seen. The green areas are that are not considered endemic. But as you'll see, Canada is green here, and you're wondering probably why we're here chatting about this today. And because dogs are infected, they remain infected for life. And we know that dogs move very easily and readily around the globe. We see cases of canine leishmaniasis regularly introduced into Canada, as well as other areas where there's not local sandfly distribution, including Northern Europe and Australia. Some of the really hyper-endemic foci, as we call it, so really well-sustained transmission is, went the wrong way, experienced in the Middle East, Southern Europe, and the Mediterranean basin, and then into Brazil and areas of South America. And as you can imagine, we have many dogs that come from these areas, including Greece and Egypt, which are common locations for canine importation. So the primary way that Leishmania species are transmitted is by sandflies. So phlebotomine sandflies. There's two big genuses. The old world, as they call it, sandflies are the phlebotomys genus that are predominantly seen in Europe and Asia. And then in North and South America, we have the Lutzomyia genus. And so these sandflies, when they take a blood meal on an infected host, so if we're thinking Leishmania infantum, that could be a dog because they're reservoirs. The female sandfly then ingests the parasite. Different transformations happen within the sandfly, and then the next time she takes a blood meal, she can transmit that parasite again. And that can be to a dog that's susceptible or to a human as they're susceptible as well. There are other routes of transmission, though, that happen in the absence of sandfly transmission, including through breeding activities as well as from mom to offspring. And these are particularly important for us to think about if we're in areas where sandflies don't exist, because transmission can still occur from an infected dog through these routes. Given that vector-borne transmission is the most common transmission and what drives the patterns of disease that we see globally, we have a little diagram here to just show sort of an overview of what's happening. So an infected female sandfly will take a blood meal, and they can ingest the non-flagellated form, so the amastigotes. And then once they're in the sandfly, they undergo transformation into the flagellated form. And then those can then be transferred again during a subsequent blood meal back to a dog or a person. And these invade immune cells, typically macrophages and granulocytes. They go back to their non-flagellated form. They can cause these immune cells to rupture, and then they're distributed throughout the body. So canine leishmaniasis is a complex disease with a variety of different presentations. And so from a veterinary standpoint, it can be very challenging to diagnose and manage. So dogs can be classified into sort of two big subcategories if we think about those that are clinically resistant or subclinical, and those that are susceptible and showing clinical signs. So once a dog is exposed and infected with Leishmania species, they remain infected and infective for life. Their degree of infectivity can vary depending on the immune response and their stage of clinical disease, but they do remain infective for life, which is very important for us to consider if we're thinking about canine importation. And dogs that may be clinically resistant and experience a subclinical infection can be tipped towards that clinical presentation if they have, other things impacting their immune system, and this can change over the course of an animal's life. And so the category of sort of clinically resistant versus susceptible is really defined by, if we're going to simply put it, there's lots of immunology here, but the nature of the host immune response. And so if there's a protective cellular immune response that's mostly driven by T helper 1 cells, we get a controlled infection. So that dog's still infected, but not demonstrating clinical signs. In the case of a susceptible animal, the host immune system is really driven by a strong humoral immune response. And this is typically associated with disease development. And there's a large spectrum of disease development ranging from mild to severe or grade 1 to grade 4. And there's guidelines that have been developed by LeashVet on how to stage these diseases. And in these cases, this humoral immune response is excessive. It's not only specific to the parasite and can be quite destructive to the host. And this is really seen by the collection of circulating immune complexes. So we have antibody-antigen complexes that are deposited throughout the body, and they lead to a cascade of different responses and a plethora of clinical signs that we can see. That will be the extent of your immunology lesson today, at least from me. If we're thinking about what might tip the scale from a dog being subclinically infected to infected, there have been some associations with breed, with boxers, Cocker Spaniels, Rottweilers, and German Shepherds being more predisposed to disease development. There is a type of genetic, depletion in which an animal is missing a certain type of carrier protein that can predispose them to clinical disease as well. And then age, we see sort of a bimodal age distribution where dogs that are younger, so less than 3, and dogs that are older, greater than 8 are more likely to present with clinical disease. Now, there's a whole host of clinical pathological abnormalities that can be seen with canine leishmaniasis, which, as you can imagine, can be seen in other diseases as well. And so the specificity of looking at some of these abnormalities and determining that this is leishmaniasis can be quite challenging, especially if it's not on your radar. You know, if the dog was imported a year or two ago, or that wasn't something that was part of the history. We can have anemia, which can be associated with chronic disease, as well as depletion in production. We can have disruptions to the clotting cascade, causing thrombocytopenia and thrombocytopenia, and secondary hemostasis issues. On your biochemistry, you can see high levels of protein, and that's really driven by that gamma globulinemia, those circulating immune complexes. Hypoalbuminemia is typically seen, especially if there's deposition of those circulating immune complexes in the glomeruli, which can lead to kidney disease and loss of protein through the kidneys. And then we see similarly that decreased albumin-globulin ratio and proteinuria associated with renal disease. There are, again, a variety of clinical manifestations, some of which can be quite general, including generalized lymphadenopathy, wasting, as you can see in this picture here. Sorry, my mouse is very sensitive. Lethargy, pale mucous membrane, splenomegaly, polyuria, and polydipsia, which again is seen in sort of more severe advanced disease. Cutaneous manifestations are some of the more common that are seen, including nodular, papular, and pustular dermatitis and nail abnormalities. And then you can also see ocular manifestations, including keratoconjunctivitis and anterior uveitis. And then some other more generalized responses as well, including epistaxis, lameness, which can be associated with polyarthritis from deposition of those circulating immune complexes, different types of vascular disorders and neurologic disorders. So as you can see, this is a very multi-systemic disease. The range of clinical symptoms is going to very much vary based on the stage of disease and the immune response. And so it can be a challenging disease to recognize and diagnose. And with that, that was sort of a whirlwind tour. I'm going to share a couple resources, and then we're going to jump into our structured Q&A. We highlight the LeashVet guidelines. So LeashVet is a nonprofit scientific global organization, of which we have one of the founding directors here today. They publish up-to-date guidelines on managing canine leishmaniasis and feline leishmaniasis. And so the website is here. I really encourage you to go there. They are excellent clinical practice guidelines. And as we talk about this today, I'd like to put a bug in your ear for 2 studies that we have ongoing to really understand more about what's going on with leishmaniasis in Canada. As you can tell, or currently we don't have sandfly populations, but we know that leishmaniasis is encountered probably on a fairly regularly basis in imported dogs. And we're really trying to get a handle more on the nature of the disease burden and the sort of clinical outcomes of these dogs. So we have a cross-sectional study in which we're sampling any imported dogs from a long list of countries. And we offer free testing for that. And then we also have a case series study in which dogs that have been diagnosed with canine leishmaniasis, clinical canine leishmaniasis, we want to follow them over a period of 2 years to understand the clinical course of disease, the challenges that owners face and veterinarians face. And this study is funded by the American Kennel Club Canine Health Foundation. And so we have a lot of support available, not only for pet owners, but compensation for professional time for veterinarians. And so if after this talk you're really interested in being involved and you have some dogs to refer, please reach out to Sydney. I'll put her email in the chat as well. It's available here. Even if you think you have a dog, you're not sure if they qualify, Sydney will be more than happy to connect you and chat with you because we're really keen on getting some more information on the current status of the disease in this country and in our canine population. All right. So with that, I would like to introduce our panel of 3 speakers, and we'll jump into our Q&A. So we are really fortunate to have 3 excellent panelists here. So Dr. Guadalupe Miro is giving us her evening. She is based in Europe. She's a board-certified veterinary parasitologist and a full professor in parasitology and parasite diseases at the Department of Animal Health at the Complutense, sorry, my pronunciation's not great, University of Madrid. She's also the lead veterinarian for the infectious and parasite disease consultation of the veterinary teaching hospital at the School of Veterinary Medicine. Among her long list of contributions, she's past president and founding member of Leash Vet International Scientific Society. Dr. Scott Weese is a board-certified veterinary internal medicine specialist with an extensive expertise in infectious diseases. He's a full professor in the Department of Pathobiology, can't even pronounce my own.
Close enough.
Departments at the Ontario Veterinary College. He's the director of the Center of Public Health and Zoonoses and the chief of infection control at the Ontario Veterinary College. I'm sure many of you already recognize his name. He's a recognized global expert in antimicrobial resistance and responsible antimicrobial use and contributes extensively to the national and global animal and public health community. And finally, and certainly not least, Dr. Christopher Fernandez-Prada is a board-certified veterinary parasitologist and an associate professor at the Faculty of Veterinary Medicine, University of Montreal. His research laboratory focuses on tackling major zoonotic parasites with an emphasis on leishmania, and does this by developing innovative therapeutic approaches. He is also the director of the Parasitology Diagnostic Service, the deputy director of the research group on infectious diseases of production animals, and the director of the Canadian Parasitology Expert Panel. So welcome to all of you. So to kick off our question, and this is likely a question for Scott and Chris, what is the current status of leishmaniasis in dogs in Canada?
You want to start, Chris?
No, go ahead, Scott. Go ahead. Yeah.
Well, it's a good question. I think that's one of the reasons you're trying to sort it out is, it's an imported disease. Like you said, we don't have natural vectors for it here. We shouldn't have local transmission, although shouldn't doesn't mean doesn't happen. And I think that's one of the things we'll probably talk about a little bit later is there any kind of dog-dog transmission that we have to be concerned about? But it is a rare disease. There's no doubt about that. It's something at the same time that we do see, Chris and I, and you get calls about them quite commonly. So it is something that's out there. If you're in general practice, you still may have a reasonable chance of seeing them because we are seeing a lot of imported dogs, and that's the risk. Long term, will we have issues with local transmission? Maybe. We're not worried about that substantially right now. So we are focused on the imported dogs. But because we have so many imported dogs, and we often don't know, like it's surprising how often you won't find out a patient is imported until well down the line, right? You're like weeks into the diagnosis, and all of a sudden, oh, by the way, he came from wherever. Does that matter? And you're banging your head against the wall. So I think this kind of, to answer your question, is it's here. It's rare, but it's common enough. We need to be paying attention to it. We have a lot of unknowns, but there are a lot of little things we need to think about in trying to make the early diagnosis.
Yeah. So yeah, we are seeing many cases in Montreal. I would say like combined like 50, 60 in the last 5 years. So for me, that's a lot in imported dogs. So we're seeing mostly coming from Brazil, Spain, France, even from Morocco. So we published a case series with that. What's scary now is that we have many NGOs that try to protect to bring dogs to Canada. So we have, for example, this case of people bringing dogs from India, and they were poor dogs in the streets. And those dogs were infected with Leishmania infantum, as Katie was explaining in the introduction. And then we were able to isolate the parasites, and we were importing not only Leishmania, but drug-resistant Leishmania, which was very scary for us. So maybe that's another thing we could discuss later on. So just to be long, as Scott commented, we are seeing more cases that we were expecting in the beginning, and we don't have much surveillance going on right now for Leishmania, in dogs at least.
Okay. So the next question, and maybe this is sort of a two-part question. So broadly, what are the clinical signs and symptoms commonly seen in leishmaniasis? And I kind of introduced some of these, but I think providing maybe some clinical experience on that spectrum and what's most commonly encountered. And then maybe in a Canadian perspective, what do these cases look like? Are the ones that you're consulting on really severe? Are we capturing them early? So looking at clinical manifestations sort of overall, and then in the Canadian context.
I don't know if you want, I'll start with maybe a really quick one. Is the ones I see are all over the board. I think we see some that are quite late and they picked up a cutaneous lesion just because they got around at the time of biopsy and it was seen histologically. We have some that, like I said before, we've got this quite advanced disease and all of a sudden we bring in an importation history that makes us think. I'd say a lot of them are either cutaneous lesions that are picked up by biopsy, or they're ones where we've got early renal disease and there's a history there and someone knows to act on that history, because getting the history is one thing and then actually realizing that that history might mean a different disease is the big challenge, because I don't think we got taught anything about this in vet school, right? So even if you find out it's from an endemic country, you have to know that endemic country exists and then think about what to do with it. I think we're getting better at that, because I certainly do get a lot more calls, I think earlier in the process, saying this dog's got renal disease, it came from here, should we be worried about it? But I would say from severity, they're all over the board. Some are quite end stage by the time we see them. And sometimes that's just disease progression. They get in very late. Sometimes it's because they've been trying to manage it and haven't thought about Leishmania. And then the derm disease, I think probably see as many of these picked up or not incidentally, but at the time of biopsy, as opposed to going in and thinking this might be Leish, let's go try to find it.
Yeah, on my side, we are seeing two kind of patients. So the ones that are the easy ones is those that have like a reactivation after the traveling. So we have the dogs and they can get kind of immunodepressed or immunosuppressed when they arrive to Canada. So within 2 or 3 weeks, they start to develop lesions. And normally when we try to trace back to the kennel or to the, I forgot my English word, to the place the dog was imported from in Europe, normally the dog was involved in a fight. So those lesions that the vet is seeing in Canada is just the bite marks or something like that. And after that, we biopsy that and we're able to see that it's specifically Leishmania that is developing the ulcers. So normally, I think Guadalupe can build a little bit on that. We normally import either stage 1 or infected clinical healthy animals to Canada, because those cannot be seen without testing, with the specific testing. So the vets are not aware when the dogs are arriving to Canada.
Yes, may I intervene? Yeah. Okay, hello everyone, and thank you for the invite. And hi to Chris, that is a good friend. And a good colleague. I would say that yes, as Christopher commented, the risk is that this is a chronic disease. So sometimes the dogs can become infected early in the first 1 year. Normally is if they have passed a risk season where sandflies are active, they can become infected if they have not good preventative measures applied. And they could be just in this silent infection that is not easy to demonstrate. Even they may have a very low humoral response. They don't have higher levels of antibodies, and if you do not perform a quantitative serology, maybe with a qualitative one, the sensitivity is less and is lower. That means that may be a negative case, that is a false negative. So those dogs can travel due to from breeders, from shelters, from animal protection shelters, with their own pet parents when they are traveling for tourists or whatever. And they are these silent carriers that are the risk for a new place where is not what they are not proven sandflies or potential vectors. But as you mentioned before, Katie, there are other non-vectorial routes of transmission that are really important. Not only vertical, that is the main one that has been demonstrated in northern areas of Europe, for example, or in the States, that has been demonstrated, these foci, but also with the foxhounds dogs, but also this blood transmission with blood transfusion, or who knows, still we don't have many information about that, but also the risk of transmission in fighting dogs that is very well recognized and very well demonstrated in Babesia gibsoni transmission. Could be a fact in Leishmania. Even we have still not quite a few reports. So those dogs must be checked up and doing blood work as much as possible every 3 months when they come from an endemic area of Leishmania, until you can get the seroconversion, and maybe just looking for target organs, skin, lymph nodes, bone marrow, conjunctival swabs, etc. You can detect the infection earlier, and the precox diagnosis is really important for the clinical management of these patients and for the future prognosis of them.
Great. That leads us really well into the next question, talking about diagnostic tools and methods available for detecting leishmaniasis. So I guess we can kind of start thinking about, maybe we have an imported dog that isn't displaying any clinical signs. How might we go and screen this dog, versus if we have a dog that has clinical signs, would the diagnostic methods differ, and what should be pursued in that instance?
I can jump in on that. So we are not lucky in Canada right now because we don't have all the diagnostic tools that our colleagues, for example, Guadalupe, they have in Spain. So we are quite limited in the testing capacities. So the idea will be testing the animals with serological tests at the beginning, and because it would be, I mean, the cheapest and a good way to assess like the ELISA or the IFA to detect the antibodies. So there are a few companies in North America, they do that. So we have normally to ship to the States those samples to be tested. So we cannot do that in Canada by a commercial route. We can do some PCRs, but PCRs can be tricky with Leishmania. It depends if the parasite is active, it's in blood, you will detect enough amount of the parasite so you are able to assess that, but if not, could be a false negative. So this is why we propose always the serological test first. And those are, you have a nice diagram to choose the order of testing in the Leish vet. So you have this decision tree that helps a lot. And then what we do sometimes in the lab, it's culturing the parasite. So you can do also cytology biopsies, but sometimes we go directly to try to culture the parasite. So that's not accessible to every vet at all. So we do that mostly in research and to try to profiling the parasites, but it's like the last step of the diagnosis, if I may say that way. So that will be my pinch of salt on that. Yeah.
I would like to add to your comments, Christopher, that it is very important to understand that maybe a PCR in blood sample could be has a low sensitivity, more even in dogs that are really not having an active infection and a real illness. And in those dogs may also, it can be just tricky to have a PCR result negative, and this dog can be positive at all and can get the infections isolated in lymph nodes or in other target organs like spleen or bone marrow. So I think that in your case, in these non-endemic areas, because you are dealing with those cases, I think that's the most important thing is the monitoring. So because maybe you are not going to get the positive dog at the very beginning, and even this dog can be not seroconverting, so antibodies can be lower than you are expecting and you cannot detect them. But if you are monitoring them, it's not just only the specific diagnostic or the parasitological diagnostic, but you, as Katie shows, our main clinical pathological disorders table that we have in our guidelines, they are really interested, because you can see a dog that is starting to have higher level of plasmatic or seric proteins, even slightly, but they are really important. And this dog can be slightly proteinuric, or may have some hypoalbuminemia or a non-regenerative anemia. They are slightly changes in the clinical pathological disorders, but they are really interesting in a dog that you have just demonstrated or tested for any other disease, or you are doing your list of differential diagnosis. You are sure that there is not anything you have to find out, but this dog, just with this travel history or this origin history, is enough to say that this dog can be sick of Leishmania, and it's important to start to look for a more sensitive PCR in a target organ, and you will demonstrate this sooner or later.
I think one of the challenges, Katie, is sometimes knowing when to test, like when to put the investment into it. So the dog that's just arrived and is stressed from an endemic area, that's an easy one. Like there are rare reports of locally acquired cases. There's one in the US that kind of got a lot of discussion a few years ago, and the suspicion there was it probably was vertical transmissions. So its mom was probably imported and it was infected, no one knew. So even if you asked importation, the dog was locally acquired. So you get into these situations where, like, the direct imported, yes, the dog of unknown provenance, well, maybe its parents came from a puppy mill or a high-risk country, then start thinking a little bit more, versus your breeder down the road who you know doesn't import and has a high health status group. Okay, you'll lop it off the list there. It's that middle group that's really tough, because testing's expensive, especially if we want to do multiple tests or serial testing. So at what point do you say, yes, we're going to put a few $100s into testing? Imported ones are easy. Beyond that, you know, the bang for buck probably isn't great, but you might pick it up. And that, I think, just something to be aware of. If we don't know, it's like we talk about with Brucella canis, another great example, right? If the dog just came in from Eastern Europe, puppy mill, yeah, it's screaming Brucella canis. But if we don't actually know where it came from, it came through Kijiji, all these kind of questionable sources, we never really know where the parents might have come from, or the dog itself might have come from. So just to be aware that, you know, we emphasize asking history of importation and travel, but lack of that, it doesn't rule it out. So, you know, do we know it was imported? Do we know it was local? And then there's that big group in between that we have to think about.
I also would stress the importance of differentiate a dog that is traveling with their family than a dog that is imported because comes from a shelter or from a hunting place, or so is just a very more at risk, this dog. But the dog that is maybe traveling, we see that in Spain, dogs that came, for example, from Germany, from central and north of Europe, and they visit our countries that are endemic, Southern European countries, but they spent only a couple of weeks, imagine in Canary Island or in Balearic Island or in whatever, the Mediterranean coast. When they come back home, in these non-endemic areas, the veterinarian must know that they are not any tool to check this dog at the very beginning. So it's important to stress that those dogs needs to wait until they can be seroconverting. That means that you have to wait at least 3 to 5 months to get a good or enough antibody levels to be detected by a sensitive technique. So that means that we cannot do just a checkup when they arrive with a qualitative test and say, okay, it's right, it's negative. So at that moment, you even don't have antibodies producing. So you only have to wait and check up these dogs and be sure that is not sick during the following months. So this is important to differentiate those dogs that are traveling with their families and dogs that are imported from an origin that is just living in a collectivity or in a shelter when the risk is really high, no? And they could be infected just from the origin country, even 1 year before or whatever, who knows? But not the same with the traveling dogs with families. So
That's really helpful to consider as well, the timing of the testing. So we've talked a little bit about diagnostic methods and tools, and Chris, you've commented that not everything is available to us in Canada. If we're thinking about management of a case of leishmaniasis, and so thinking even across that spectrum, so we have a dog that is positive, we've screened it, but not demonstrating any overt clinical signs versus other dogs that do have clinical signs. What are the treatment options and how should veterinarians manage those cases? And maybe Scott and Chris, you can kind of add in the unique considerations in Canada with our access to drugs and treatment options as well. Sorry, that was a bit long-winded.
Go ahead, Scott. Yeah.
Well, Chris will probably comment more because I follow the Leishvet guidelines. I think that the Leishvet gives us a really good guidance of the drugs. So really, it's important thinking about the stage of disease that we're at for anti-leishmanial therapy, plus our supportive therapy, which as you progress through the stages and you have more advanced renal disease, starts to get into some polypharmacy, dealing with renal disease, proteinuria, all the other supportive concepts. But the Leishvet guidelines are very good. The challenge we have in Canada is access to the drugs. With meglumine being the easiest one to get through EDR. And if people need the drug and haven't used the EDR process, emergency drug release process, it's actually very simple. And it doesn't take very long. It's 2 pages of paperwork, but that's how we get that in. Miltefosine has been a challenge because I'm not sure if you've had more, we've been trying to get access to that for a while with the EDR process in Canada. So basically what it is for drugs that are available elsewhere but aren't licensed here. So it's the onus on us to bring the drug in and assume responsibility for it. For us to get a drug via EDR, we have to get it right from the manufacturer. So you can't go through a pharmacy in another country or a distributor in another country. You have to go to the producer. So for meglumine, that's BI. You have to get it from them. So you have to find the manufacturer that's willing to sell it to you. And sometimes they're not, just for hassle, logistics, various other reasons. Fortunately, we've been able to get meglumine typically without any problems here. Other drugs, not so, anti-leishmanial as well, miltefosine, basically not so much. So we've got allopurinol, we have meglumine, we have domperidone, as I would say the 3 things that kind of I look at for for our treatments beyond the supportive care. But I know, Chris, you'll jump in. You'll have the life vet side much stronger than me.
Yeah, no, I think one important fact that the vet should know that there is not clinical, it could be a clinical control of the disease, but you cannot kill parasitologically the animal. So sometimes it's a treatment for life. So it's many dogs will receive many cycles of drugs. So at the end, we think that the parasites will become resistant or less sensitive to those drugs. And then the quality of life of the animal will degrade with time. So because all the function, the renal function and other parameters would be altered in the dog. So it's quite tricky for a vet that is not used to treat leishmania to adapt even the beautiful protocol of the Leish vet guidelines. It's really nice, but maybe Lupe can talk on that. She has treated most dogs that anyone, I think, for leishmania. So it's quite challenging, and you never know the drug resistant profile of the parasites that are in those animals. So it's at the beginning it's a say error approach. So sometimes we have to switch from antimoniate to miltefosine, and for example here in Canada it's quite challenging to get miltefosine. Coming back to the cases I was telling that came from India with drug-resistant parasites, we have the proof that we have to treat with miltefosine, so we were able to import from France. So it was super challenging to get that. So yes, and now we are trying to see if a combination of treatment with allopurinol, either antimonial drugs or miltefosine, is working better than allopurinol alone. I've seen many vets in Canada using allopurinol alone because it's easier to get compared to other drugs, but the control of the disease is not the same at all. So, yeah. So
yeah, and this is, I think, where, and I mentioned your comments on domperidone too. I think the hope with domperidone is we help with that immune response so that we maybe prolong our ability to control disease. But I think your comment about this isn't a UTI where you treat for 5 days and you're done, right? This is a long-term management. Owners have to be prepared for the long-term treatment, testing costs, and the unclear prognosis. And most people don't really understand that. They think about infectious diseases as something that happened, you get better or you don't, but you're done right away. This isn't one of those.
Well, I think that it's very challenging, the treatment of these patients for everybody, even in endemic areas. And maybe just to differentiate a little bit, or to try to split different type of patients, I would say that when you do a precox diagnosis, so an early diagnosis in the very early moment of getting the infection, and when this dog is just a stage 2, meaning that you can consider it sick, very, or not very, but a moderate disease, those dogs just have a very good recovery from the treatment. That is just the recommendations with meglumine plus allopurinol. Allopurinol is very important at that moment because it's a very synergic drug, and if the tolerance is good, because there are other dogs that may have some intolerance, we can discuss later on. But with the cycle of 4 weeks of antimonials plus allopurinol during at least 6 months, those dogs going very well. So in the stage 2. And but again, the most important is to diagnose them as soon as possible, as soon as you start to see changes on those animals. The problem or the difficulties appears when you have those dogs that has received other cycles, or because they are just sick for the last 3-4 years or whatever. So these chronic dogs are the most challenging. But well, we have an average in endemic areas of a 1 year relapse. So 1 relapse per year. So this is at least considered normal, and we are not worried about that. So this is a normal way of managing those animals. But the treatment for life, I would say that we don't like to say that because we need these dogs just to get some rest of drugs, and sometimes it's good to leave them maybe only with immunomodulators at some point, waiting with nucleotides, maybe even more interesting than domperidone, that can have an impact to the hypophysis or to the prolactin metabolism and so on. So sometimes it's not the best for using in a long term, of course, but we need to take a rest of drugs, because in one hand, we are just having the risk of creating resistance, of course, that it's a fact already, but also because we need to try to demonstrate if this dog can start again with a Th1 response, and is be able to respond to the infection by itself, not with leishmaniasis at all. So we don't need to kill leishmanias every time. So this is also an important point to consider, no? And domperidone, talking with Scott comments, has not been proven for sick dogs. So it's interesting in early stages, in stage 1, or even in clinically healthy dogs, to keep them in a good shape and not or just not getting sick or getting a moderate disease. But in sick dogs doesn't work, not at all. And I also agree with Christopher that the use of allopurinol alone in a monotherapy is not very useful. Also in sick dogs in stage 2 and stage 3, you are losing time. You are losing time. You need a leishmaniasis drug from the very beginning to start to kill parasites, to reduce the parasitic burden, and then try to keep them or to maintain this leishmaniasis effect with the leishmaniostatic effect of the allopurinol. The matter in our countries, in endemic areas, is that allopurinol is using much than ever and much that we need. And this is a very important worry because we are receiving, I work in our hospital in Madrid, and there is a lot of animals referral cases that comes with nephrolithiasis, with really severe renal disease due to the long-term use of allopurinol without needed. So this is an important concern that we need to stress the need to run urinalysis from the very first minute in a dog diagnosed with leishmania, because you need to follow up these maybe side effects of other adverse effects with the bad metabolism of the allopurinol that is not very common there are some dogs that are very good responders to allopurinol, and they can have it in high dosage forever, but there are others that become sick because you are not using the allopurinol in a good way. So we have to take care of this, doing urinalysis and doing ultrasounds, imaging at least once per year in these chronic cases.
And maybe a question for Guadalupe and Chris. Marbofloxacin, have you used it, or what are your thoughts about it? Because it gets mentioned as a treatment. I'm always wary of it because I haven't been convinced of the data. Plus, I just think we're making big cesspools of fluoroquinolone resistant everything in these dogs if we go 28 days of fluoroquinolone. Plus, they're not particularly benign drugs themselves, but I don't know if you have any thoughts about that. That's my biased approach.
No, you are just talking about a very important point of view, and I fully agree with you. So marbofloxacin, there are not enough evidences to use it as a first-line drug. And of course, considering you said that you are working on antibiotic resistance, so you know more than me how important is the responsible use of antibiotics in any clinical act or in any clinical case in our practices for other diseases. And of course, marbofloxacin or any other quinolones must not be the first line, and of course is not the leishmaniasis effects is very low comparing with miltefosine or antimonials. So I do not recommend it at all. Of course, if you have a uroculture positive, so you have an urine infection and you are doing a good antibiogram and you have just a positive results and the quinolones could be the first option, maybe you can use them in those dogs with leishmania, because we know that has a relative effect on leishmania, but not because it's just an antibiotic that you have read that is useful for leishmania dogs. So not at all. I fully agree with you, and I think it's very important to remind this. Thank you.
Yes. I guess building on that, because this was mentioned earlier, Chris, and the concept of drug resistance. So what are we seeing sort of globally in the patterns of treatment? And I guess what are some of the concerning trends?
Yeah, I will say that that's really tricky as a question, because we don't test for drug resistance in the clinic setup. So normally you can see a relapse, you can see a treatment failure, but from that to being able to assess the parasite and to see if there is something in the parasite that has changed, making them resistant, it's another story. What I can tell you is that we are conducting studies in different countries, and we are seeing an accumulation of resistance in time. So maybe the strains that we are seeing now in dogs and humans are more resistant than strains that we saw in the past 20 years ago. So there is an accumulation of drug resistance. For sure, there are several clinical isolates that have been really well characterized, both phenotypically and genotypically. So we can assert that they are drug resistant. But in the clinic, it's quite difficult. For some cases in the Montreal area, in the province of Quebec, we are culturing, as I told you, the parasites. So we are conducting a drug sensitivity test on those parasites, especially if they come in from India or countries where antimonial drugs have been used for more than 100 years in humans. Because that's the other piece of the puzzle, is that it's affecting both humans and animals in endemic areas. So it's quite challenging because we are treating both humans and animals with the same drugs. So there has been a natural accumulation of drug resistant, not natural, I would say forced accumulation of drug resistant through many years. But right now, we don't know the extent of drug resistance in the field. Yeah,
Something
I think
to be aware of, sure.
May I comment?
Yeah.
Yes, I think this is really an amazing field to study, no? And maybe in your country, in a non-endemic area, you are the ones that can follow up dogs that can be just having a low efficacy of the treatments more than in our endemic areas, because we cannot differentiate a relapse versus a reinfection. So that's the point, that every year those dogs can be infected again. Of course, if you are using those synthetic pyrethroids, these preventative measures, even doing everything, those dogs are not living in a bubble. So they are just being exposed to a very high pressure of sandflies infected. So at that point, we cannot say that why this dog is relapsing, because maybe he's living in a very endemic area and they are becoming infected. But if I would say, what about our figures in Europe, in Southern Europe, in endemic countries like myself, working in Madrid or in all the center and east of Spain, I would say that we don't have many dogs that are resistant, literally. I mean, like they need just a cycle of treatment every 2 months or every 3 months. That is the ones that are really difficult to manage. The mostly whole population of dogs, if you manage them in a right way, they are not relapsing every 3 months. I would say in my mind that I have only 3 or 4 dogs, but in 2 to 3 years. And the rest that I receive every day, 11, 12 cases that I see, they are responding well to the treatment. So it's a question of diagnostic and differentiate from other diseases. That is the problem in endemic areas, that they must have other comorbidities, other co-infections. So sometimes they are not responding well to the specific treatments against Leishmania because they also may have other diseases that are contributing to a worse prognosis and bad management.
Yeah, and I thank you for that, Lupe. It's what I would like to add is like we have a tendency to think that drugs for Leishmania were developed for Leishmania, which is not true at all. So they were developed for other diseases, and even antimonial drugs is just metal poison. So I don't even consider a drug. It's a poison, so it's super toxic. So what is happening in Leishmania is it's quite different than most of other infectious diseases, that you have one specific mechanism of drug resistance associated to a drug. It's like, as this drug is like shooting like with a cannon to the parasite. So there are many pathways or many metabolic pathways of the parasites that get affected by the drug. So there is an accumulation of small resistances in time. So it's not one specific gene that's going to be responsible for massive resistance. So what we think now is there is an accumulation in time of small changes in the evolution of the parasite. So that could explain partial sensitivity of the parasites, but could also explain at the same time some relapses that we are seeing right now. So I think it's both drug resistance and the lack. I would say, as Lupe said, that the most important thing is that the lack of diagnostics right now and the ability to follow up the disease as we should. And because of that, we are using drugs maybe not in the most optimal way that could be used for treating Leishmania.
So the next question I have for you, and I'm starting to sort of combine questions between our open Q&A and our structured Q&A now. So what measures should we be taking to prevent the introduction and spread of Leishmaniasis in Canada? And I recognize that that's a fairly contentious question, and there's probably a lot of divided thoughts on that. And so any insight or recommendations you have?
I think Scott should go first.
Throw that one at me. Introduction and spread are different things, right? So introduction comes down to, like, there's no way we can prevent introduction. It's just impractical. Even if you put really strict measures, you can't identify everyone when they show up. You've got this lag period. I think what we mentioned, that you've got time to seropositivity. So you've got even an exposure. If you really wanted to have a control measure, you'd test them before they left. You test them at arrival, you would isolate them, and you would test them at a defined period later before you release them. Or we're not going to do that, right? For lots and lots of reasons. So I think part of it's awareness. We were seeing situations a few years ago where people were bringing in known Leishmania positives, and the rescues were saying, "Oh, you can treat it. Don't worry about it." So I think we've gotten around that with most of them now, because people really got surprised with what they got into. So there's an educational component. There's reducing the numbers by testing before they're exported. So a good rescue that will test is not a guarantee, but it's an improvement. But we're never going to eliminate the risk if we're moving dogs. Local spread, like, we don't have the insect vector that we know of. So local spread comes down to movement of blood, right? So that's vertical transmission through breeding, that's biting or bites in general, transfusions, needle stick, sharps handling practices. And that's where you get into the public health components too, because if we can spread it dog to dog, we can spread it dog to person. So from an importation standpoint, I think really we need to focus on awareness, trying to reduce importation of known cases, trying to identify the cases as early as possible so we can deal with them sooner, so we don't have to deal with them at stage 3. You can identify them at the start. once they're here and they're positive, and the quicker we know, the more we can contain it, the more we can reduce the risk of transmission, the more you can make sure these dogs aren't breeding. And part of it, I think, for us in the veterinary side is upping our game a little bit with needle stick injuries and sharps handling and blood transfusions and the like, because we just don't do that very well. We're better with blood transfusions. I think we're paying attention to that. We've got good guidelines for that. But needle stick injuries are really largely assumed just to be a day ending in Y in veterinary medicine, right? The number of times I got stuck with a needle in my life is pretty impressive. And it's completely different in the human field where this is a major event. In the veterinary field, like it's all whatever it hurts, off you go. And most of the time it's not an issue, but we do have issues with drug reactions with various infectious diseases. And this is one that we have to have on the list there, because needle stick's been shown to I'm not sure if there's documented dog to person. There's documented person to person transmission via needle stick. So if you can transmit it from a person to a person with a needle stick, you've got to be able to transmit it from a dog to a person with a needle stick, I would assume. So I think we have to just consider upping our routine sharps handling game. And with known and suspect cases, just, it's not a matter of doing anything different. It's just doing the stuff that we should be doing better. When it comes to breeding, if it's an imported dog or a dog of unknown provenance, testing before breeding, just like we would do with, again, back to Brucella canis, some of these other insidious things that we can be bringing in so that we're not amplifying that. And then bite transmission, other blood transmission is going to be an ongoing problem. Again, the sooner we can identify the high-risk animals, the more we can be more aggressive with containment.
Go ahead, Lupe. Yeah. No, go ahead.
Well, no, I wanted to stress that do not forget with these imported dogs to look for other infections like tick-borne diseases that may be more common even than Leishmania or whatever. So because they are immunocompromised, sometimes they have endocrinopathies, they can have neoplasias, they can have demodicosis, other diseases, systemic diseases that can mimetize with Leishmania, and you are looking at the dog with cutaneous lesions that maybe are not mainly due to Leishmania infection, even if they are positive to Leishmania. But if they are not having or the treatments are not doing well and they are not recovering from the specific treatment, reconsider the diagnosis and look for other co-infections or other comorbidities, because they come with a big of surprises, I would say.
Yeah, and I think that's super important, because we start to see Leishmania when we look for Leishmania, and so there are many other things that we are not finding because we are not looking for them. So there are many vets now that
Sorry?
Sorry. Yeah, so there are many things that we find now
I
that
didn't hear you.
Oh, can you the rest of you can hear me?
Yeah, I can hear
my connection is doing bad.
Okay, yeah. So I think it's Lupe's connection that it's a little bit
I'm
slow.
sorry.
No, it's okay. It's okay. So I was saying that
Maybe it's doing something.
Wait a moment for the delay. I think now it's good. No, she's frozen. Okay, so yeah, so
I can try to change.
So yeah, with importation, we start to see Leishmania because we start to stress a little bit the fact that maybe Leishmania was present in those dogs, depending on the kind of lesions that we were seeing. So we start to investigate a little bit more Leishmania. But as Lupe was saying, there are many other things that we don't even suspect. So what we are doing now is trying to work with vets to educate people that want to import dogs or to bring dogs to Canada, to show the amount of disease that could be present, not as a barrier, but just as a point of information to know what are the different battles that we'll have to fight maybe in the future. And so the person who is importing the animal can prioritize and decide if importing the dog or not, and the risk and the cost in terms of animal health, but also in money. So we are trying to do that, and it's quite interesting. We try to do some more outreach for Leishmania, in the media, and we were apparently fear-mongering people with infectious diseases, which is, it was quite funny. After COVID, people, it's tired about diseases, so every time we try to explain that there is a new disease maybe coming to the country and should be careful and testing, they don't like that. So as Scott was saying, we should build a little bit more in education and try to train both vets at the school, vets through continuous training, to be able to transmit to the owners or to the importers the risks and the solutions that they could apply.
I fully agree with you that it's a very important question about the continuing education, and yes, and even just we are educators, no? When we are just dealing with a case of a zoonotic clinical case, just to contact with the family and to explain all of these things are really important, no? In order to, well, to create more awareness about that and to try to improve the preventative measures, no, at all, and to do a responsible importation of animals when they are breeders or they are working in animal protection shelters. We have the bad experience from the south to the north and center of Europe, and we are importing a lot of clinical cases because there are not enough responsibility from these shelters, and they are moving animals that are already infected and become sick after the immunocompromise of the traveling. So this is a really important question, just to do a sanitary education at all.
There's a couple of questions in the chat that relate to the zoonotic aspect of leishmaniasis. And Scott, I think you touched on that a little bit with prevention and needle stick injury. I'm wondering if anyone wants to expand a little bit more on that, about how zoonotic transmission occurs. And there's also a question if humans are infected for life, just as dogs are infected for life.
I can talk a little bit about transfusions and blood. So yeah, so it's not clear if just sticking a needle will transmit leishmania. Even if you try in the lab to infect a mouse with leishmania, just sticking the needle is not as effective as a sandfly. So a sandfly can transmit with 600 parasites, and sometimes you have to put 10 million parasites with a syringe to be able to infect an animal. But what was happening with the transfusions or the blood or sharing needles, it was during this period, especially, I know in Spain, in the dark period of drug addiction that we had in the past, so people was not only sharing needles, people was extracting blood and mixing with the drug. So it was large amounts of blood that were transfused between people. So it was not just the peak of the needle, it was a real transfusion that people was doing for doing drugs. So that it's hard to find in the literature how this kind of transmission is declared, but normally in humans it's hard to find the parasite in circulation in blood. So normally you have in the lymph nodes, in the spleen, in the liver, in the bone marrow. So it should be high volumes of blood to be able to get this kind of transmission. Not impossible, I agree with that. So any kind of infectious transmission could happen, but it's maybe less risky than we think. And maybe I'm undermining the risk, but to our knowledge, it's high volumes of blood.
Yeah, and then lesions would be the other one. So if you're aspirating, and that's the human case, I think, was a fine needle stick from a skin lesion, right? So you're getting right into where parasite burden is going to be higher. So yeah, I would agree. The risk is probably low, but not zero, right? And I think it comes down to, we can do some pretty basic things. The bigger risk would be a laceration at surgery, where you get a large, like, it's volume of blood. Or if you're excising a lesion and you had a laceration that way, that'd probably be the highest risk area. But I think it's a matter of, we've got simple precautions to avoid blood transfer from our patients. So, there's not a downside to not sticking yourself with a needle. But particular care with biopsies is important, because we do see needle sticks that happen around fine needle aspirates.
Yes, I would say that there are no reports about the transmission from sick dogs or infected dogs to humans living in the same household. So not at all. In endemic areas, we have another scenario, of course, because the way of transmission is that if we live in an area with sandflies that are infected from dogs or from other hosts or from wild hosts or whatever, we are at risk. But if we are immunocompetent, if we are not at risk, really. So the differentiation is when we are immunocompromised for any different diseases that are really demonstrated that you are at risk of many infections. And one more would be that the sandfly can infect you and transmit you the Leishmania parasite. But in general, I would say that the direct contact is not has not been demonstrated from dog to human beings, and that the most critical point is this blood transfusion, and that is not really now a problem, no, because the management of the blood in human beings just destroyed this parasite, and you are not able to get infected. But just historically talking, we had the problem during the 90s, 80s, mainly, that the HIV positive humans were infected by needles when they were sharing needles because they were drug users. And in that case, the demonstrations between the needles, so this little amount of blood that keep in this needle that they were, these syringes that they were sharing, was the problem or the origin between an HIV positive Leishmania infected human that transmits the infection to another one. But firstly, they were HIV positive, so was really a different scenario. But there are not new reports about that. So yeah, I think it's not very important topic in general.
Yeah, I think the emphasis of low risk in the household is really important because people will read things about transmission and blood and bites and the like. And I think owners need to differentiate bites from fights, which, you know, we talk about bite associated, but it's blood transfer, and a little nip is probably not transferring blood from that animal to you. It's exposing your blood. It's probably more of a fighting where you get tearing in the mouth and then you're getting biting that's driving blood in. So, you know, I tend to really emphasize the negligible risk in the households. That said, you get the odd household case where you've got a dog and you've got a housemate that's from Canada that's come up positive. I mean, we see these really sporadically, and that raises questions. Is it just, you know, there's that type of contact we don't know about? So I very rarely say never with infectious diseases. It's a great way to get burned. But I think for owners, we really emphasize that it's blood and its volume of blood transmission. And presumably that risk drops when they're treated too. And we're not using anti-leishmanial, but if you drop down the burden of parasite that's there and you improve the animal's immune response, you're probably improving your risk there too. So the biggest risk to the owner probably has been before the diagnosis, and once they know some basic handling issues and treatment has started. But yeah, we want to make sure that the biting aspect is controlled. So we would talk about trying to reduce bites as much as possible, but it really probably is more of a fight than a bite risk.
A question from our participant. With the new rules of importing dogs to Canada, I'm assuming these are the prevention of commercial dogs from high-risk rabies countries. Are we seeing less cases of canine leash?
I don't know, Chris, are you seeing less? I think it's hard to say what it would do because it's not meant to design, it's not designed to reduce lice. It's designed to
No.
control high volume imports from high risk countries, which will have an impact because we did see some of those, right? Large numbers of dogs coming from high risk areas. So there's probably going to be some effect. It also, I think, weeds out some of the dodgier rescues that don't want to put the time and effort into it. So you're selecting for groups that are putting more effort, have more expertise, and are probably more likely to do things right, including testing and communication. So I think there might be some indirect effects, but we still can have personal pet importation. You could have importation from countries that aren't on a high-risk rabies list, but are on a high-risk lice list. So it's definitely not, guaranteed to do a lot. I don't know whether you're seeing fewer cases in the last year or so. I'm not sure it's much.
I would say no. And the thing, especially in the province of Quebec, is that there is like a direct bridge, for example, with France and Spain. So there is more connection. So they're highly endemic and less, I would say, surveyed countries for that. So there's less suspicion that a dog is coming from France, has a parasite, that a dog is coming from another country, if I may say that way. So there is less initial suspicion. So this kind of problematic we're still seeing. I think that the government tried to implement a mandatory deworming from dogs, but those dewormings are not working for leishmania, so there is no guarantee that if you give those drugs to your dog before importation, leishmania will be there if it's there. So we are trying to advocate to work with a vet in the endemic country to guarantee at least health status of the dog. I won't say a negative test, because as we discussed today, there could be many factors that could influence that, but at least the animal has been healthy for X months or weeks, and to propose follow-ups to the vet that it's in Canada to be able to take the case when the animal is here. So we are trying to work on that more than to stop importation, because as you said, it's impossible to stop importation, especially for individuals.
But maybe it could be interesting to try to ask them for doing a quantitative serology test before leaving the endemic country, because this is important and could help at least to know the serological status at the very beginning. So in dogs with more than 3-5 months could be a good tool, but a quantitative one.
That's a really good point. Yeah.
Another question, can we learn from surveillance done in countries that are endemic for canine leishmaniasis? So are there things we can bring back if we were to conduct surveillance in Canada? So I guess that's sort of thinking about what surveillance, if any, exists in other countries, and are there things we could consider here?
I think for me, like surveillance, it's what's the action step? Like surveillance is all fine and dandy, but you have to actually do something. You could spend a lot of money doing a really big surveillance study in Canada saying, yes, the 0.001% of dogs are positive and they were all from overseas, or almost all. So I think it really, like the surveillance effort, like we were saying, like that, focusing on the imported dogs to have an idea what the problem would be, like that would be the way to do it, and really test them at admission to the country and then test them a set period later to really get an idea of what we're bringing in. Because we have a different situation. Like that's our focus of infection. If you're an endemic country, you've got things you look at, temporal changes, you can look at regional changes, the impact of climate on vectors, and all these other, you've got some really interesting questions you can answer that can define risk and avoidance, but that's different than we've got here. So I think there are limits in what we can extrapolate from surveillance. We can definitely extrapolate their treatment, prognosis, all those other things, because at that point the animal's the same. But I think the surveillance goals in an endemic country are going to be completely different than our surveillance goals in a non-endemic country.
Yes, I can add about your comment, Scott, that for me is really clear that in endemic areas, surveillance are really useful because dogs are good sentinels of many infections and many zoonotic diseases. And because we know that due to the climatic changes and globalization and movements of animals and people, every type of transmissible disease is is going up, no, in this global warming world. And in our country, for example, in North was free of leishmania in the last 20 years ago, and now we have cases, autochthonous cases. So in these places, the surveillance are really useful because we can detect how leishmania is moving, and even surveillance for sandflies. So we are trying to put light traps in areas where never we have found sandflies, and now we are having the opportunity to detect them, and even they are infected. So that is the meaning of the useful of the surveillance. And in Madrid, that is a very endemic area, we are doing a surveillance for the last 25 years. Every April and every October, we are checking 100 of animals in different shelters. So they are living in animal protection shelters. So they come from the street. So they are feral or stray dogs. And we are just doing this serology test on those animals just to follow the trends of the infection in a very important population that is the stray dogs. And they are giving us, this surveillance are giving us a lot of information. So, but in a non-endemic area, just to spend money looking at leishmania and serological status in dogs that have never go to an endemic area, I think is maybe useless, no? But that's it.
Yeah, I fully agree with both of you. So I think if I have to put my money, it will be on education and to try to get tools to the vet. So being able to use diagnostic tools rapidly rather than have to wait or have to get a release of the drugs when required. So I think that building a case that we should be prepared and not reactive, because normally it's what we do in non-endemic countries is more like a reaction way of thinking. So maybe we can build a little bit on preparedness and try to get the tests working in Canada, to get vets educated in how to use those tests, how to do the interpretation, and then moving forward, maybe in the future, I hope not, that if it happens that endemicity gets established here in Canada, we will be prepared and we will be dealing in another way with the disease. So I think we can learn from that. We can learn from endemic countries. As Lupe was saying, if we can use those dogs that are coming to Canada to understand better what it's a clinical, a treatment failure or drug resistant, to try to understand better the dynamics of disease and resistance, that will be quite helpful for everyone. So I think we can get prepared. So I think that's the positive message.
Yeah, and also that's it, monitoring those positive cases living in your country. It will be absolutely useful to get more knowledge about how it's the behavior of those infected dogs in a non-endemic place where they are not sandflies vectors. So you can see these other routes or never exist those routes. So it's just monitoring those positive dogs. I would spend all my money on this.
Yeah, and it's been a bit on the close contacts too, the household contact dogs, just to help define what types of dog-to-dog transmission, like, is it all, are we seeing it, is it all known from bites? Is it like, what are the circumstances around that? Just because, you know, that's the next level of concern, right? The dogs that brought it in, then is there that potential limited spillover? But yeah, I think focusing, it'd be really interesting to get some longitudinal work, which is always a challenge. It's really hard to do, expensive to do, but that would tell us a lot when you don't have to worry about reinfection.
Yes, those clinical cases are amazing, no? To learn how they are just changing their status.
I'm muted, sorry. I see we're at 1:30, so we're at the end of our Q&A. There was a couple questions we didn't quite get to. I'm not sure, Chris or Scott, if you can see them in the chat and might be able to type the answers. As we sign off for today and talking about monitoring clinical cases and getting information in our own country. I'm going to repost our studies. So hopefully you take a screenshot. This will be recorded. If you're interested in becoming involved, we really would like to boost recruitment and get some more information. But with that, I'd really like to thank Scott, Chris, and Guadalupe for your really great conversation, and thank CAHSS for sponsoring this webinar today and everyone for coming. So I'll hand it back to you, Doris.
I don't have anything else to say, but like Katie said, thank you so much. I learned a lot. I took a lot of notes, and what we'll do is we'll send these posters that Katie's put up along with the RAISE CE certificates in the next few days. If you do have any questions for our panelists after this webinar, you could certainly email us and we could forward it to them. And our email is CAHSS, so CAHSS @animalhealthcanada.ca. So I'm going to just quickly put that in the chat, and we'll hopefully see you guys next at our, I guess, future events that we have. So feel free to just bookmark our CAHSS events calendar, and you can see all of our future webinars and sessions there. Thanks so much, everyone. Have a good day.
Thank
Bye
you
now.
very much.
Thank you.
Good luck with your study.
Thank you, Lupe. Thank you very much.
Thank you, you all. It was a pleasure.